Welcome, everybody, to the Fibrolamellar Cancer Foundation series of educational forums for patient and professional interaction on key topics you, our community, have noted to us are important. Hey, I'm John Hopper. I'm the president of the foundation. And for those of you new, you might say, who is the Fibrolamellar Cancer Foundation? And very simply, we were founded in 2009 by fibrofighter Tucker Davis, who was diagnosed at the age of 26 with fibrolamellar. And Tucker and his friends created three key missions, which we've been true to for the last 12 years. A, research in terms of finding the cure. Two, education and awareness so people understand and know about fibrolamellar. And three, and importantly, building a strong patient community, particularly a community that will help accelerate research. We are also the winner of the 2020 Chan Zuckerberg Initiative of the Rare as One Award. That's Mark Zuckerberg, Facebook's big foundation, and we're proud to be part of that. Over the last 12 years, we've funded nearly $10 million in research across 20 institutions. And the big thing for us is collaborating across all the research institutions, medical institutions, and also the other patient support communities that are out there. So tonight, we have a great panel discussion for newly diagnosed patients and their families. This event will present real-world information on what newly diagnosed patients often need to know. So let me introduce tonight's special panel. First of all, it includes Eucharia Borden. She's the Senior Director of Health Equity and Clinical Services at the Cancer Support Community. Eucharia will address unique non-clinical patient and caregiver needs from the perspective of an oncology social worker and a patient navigator for newly diagnosed patients. We also welcome a great friend of the fibrolamellar community, Dr. James Geller. Dr. Geller is a professor at the University of Cincinnati. Nationally, Jim also serves as the co-chairman of the Children's Oncology Group, their liver tumor protocol, and the Pediatric Hepatic International Tumor Trial. That's a mouthful, Jim. Hey, listen, tonight, this is going to be very interactive. What we'd like you to do is in the chat button on the bottom of your screen, take a moment to write down any topics or questions you would like our experts to help address. The more we have you populate that, the better it is for our panelists to basically lead the discussion on this, which is fairly informal. Always, I have to note that the Fibrolamellar Cancer Foundation does not give medical advice. These webinars are for your informational purposes and resources to help you make the best decisions possible and help in your journey. So with that said, everybody here join in welcoming Eucharia and Jim, and you guys, you're on.
Well, thank you, John. I appreciate the opportunity to be a part of this event, and always excited to interact with family members or patients who are experiencing fibrolamellar cancer. And I am available to discuss anything that's of high priority to our audience today, who hopefully will be more than an audience and be participants. So I am an oncologist, and I'm a pediatric oncologist, and I don't know the age of the people who are out there on this conference, but fibrolamellar cancer, as people know, affects teenagers and young adults predominantly, although not exclusively. And it's both pediatric and medical, that is adult oncology groups that get involved and ideally collaborate. And I imagine some of the challenges for new families, which I believe is the focus of today, starts with the symptoms, and whether it's discomfort in the belly or weight loss or pain or whatever it is, something has happened most of the time. Sometimes people just find this out incidentally. And it usually starts with either the family physician or a radiologist saying, we've got something here and you need to see a specialist. And from there, I imagine Eucharia is going to help guide us through how to navigate the system and advocate for yourself. I will comment that at some point you're going to be referred to somebody, either a surgeon or an oncologist. And it's not actually always the same. Some people will refer to a surgeon, and some will refer to an oncologist, but what you're going to need is you're going to need both. You're going to need pictures that look at your body whether it's a CT scan or an MRI or a PET scan. There are all sorts of fancy scans that I can talk about what each of them do. And someone's going to say that we need to get some tissue to understand what this is, not thinking it's going to be fibrolamellar cancer. They're going to be thinking it's something else. It could be hepatocellular carcinoma, or if you're younger, hepatoblastoma, or something not cancer at all. And you might get referred to an interventional radiologist, who's a doctor who'll do a biopsy through the skin, or a surgeon to get tissue. Sometimes, depending on the imaging, they'll refer you just to take the whole thing out right from the beginning. And those decisions are nuanced, and it depends on how you present and what your situation is like and what your scans show, both in the liver and outside the liver. But that diagnosis phase is about meeting the team, getting a team that can help support you, and getting you the earliest answers about what this is. And oftentimes it's a surprise, not just to you, but to your team, that this is rare fibrolamellar cancer. Now, in the community that we exist in, it's not that rare, because we all hear about families affected by this fairly frequently, but it's, in the grand scheme of things, it's rarer than the other forms of liver cancer. So that raises questions. Does your doctor know about this, what this is? Do they know what to do? And in general, most oncologists and surgeons can navigate through this, and I'm sure you'll get good advice. But it's not unreasonable if you hear that word fibrolamellar, what is this? To say, where do I go? What do I do? Do I need a second opinion? Is this, what do I do from here? And there are some specific things that you'll do. You will get an oncologist, you will get a surgeon, you will have some laboratory testing done that is routine. And then the decision becomes, do I just have an operation? What did my doctor tell me about the tumor, whether it's resectable or not? Did I hear this word liver transplant or not? Where are the most common places this goes, which is, the answer is the lymph nodes in the lungs, the lymph nodes around the liver. How do I know if it's resectable? What does my surgeon think? What do other surgeons think? And the answers aren't always straightforward, and that's where the second opinion can become helpful. And because the treatment's going to involve at minimum surgery, but more likelihood medicine is as well. And there's not uniform agreement about how to medically treat this either. And you might find that one doctor's telling you one thing and you heard online that someone's doing something else. And that's where a place like the Fibrolamellar Foundation can be helpful, because they hear the opinions from all sorts of different people. And sometimes finding that resource and to give you a little bit of flavoring of what the field is thinking about can be helpful. I'm not sure what questions are of high interest to all of you. I'm happy to go through the diagnostic phase, the staging phase, the treatment phase, what a team looks like in more detail. But I'd like to kind of pause and see if I could get some questions from the audience, either via chat, and John and Kurt, hopefully you can help navigate that, or otherwise, or if there are other topics that the Fibrolamellar Foundation would like me to dive into with more detail, I'll kind of take my cues and go from there.
Hey, thanks, Jim. Right now, I don't see anything in the queue, but I'm sure there will be along the way. So maybe we'll pass the baton over to Eucharia a little bit so she can talk about the perspective that the cancer support community takes on this, and then we'll consolidate questions and go from there. Thanks so much.
Sure thing. Thank you for having me, and I'm so glad that I get to be here with you this evening. Right now, I imagine you're feeling and thinking a lot of things, maybe too many things at once to even tease them apart, to form them into questions, which might be why we don't have any right now. I'm an oncology social worker by training, and I currently work at the Cancer Support Community as Senior Director for Health Equity. And in my role, I'm focused on serving patients in diverse communities as well as their loved ones. But I really just want to talk about what's happening right now. As an oncology social worker, I'm usually the person, or we as a community are usually the people that folks don't want to see sometimes. They hear the word social worker and, probably like me, before making career decisions had preconceived notions about what a social worker is or what a social worker does. And I've even had a patient come to me once and say, my surgeon sent me to you, but I don't need you. But you can tell me what you do, but I just want you to know I don't need your help. And I had an opportunity to connect, to talk about what I do. And that's what I want to do here this evening. Social workers do many things. In the treatment team, we have a major role. People frequently hear about doctors and nurses, but the oncology social workers on the team are the ones who help with all the other things that are going on in your life. We work as an integral part of the team, not as an afterthought on the team. So when people are wondering, I wasn't expecting this, what do I do about work? What do I do about the rest of my family? How do I pay for this? How do I even get here? All of those kinds of things are the kinds of things that I address. And where I begin with a patient is not the same as where I begin with another patient, because all families are unique, all situations are unique. And while you may have some of the same concerns, they're different to varying degrees. And so I also want to pause to give you an opportunity to just begin to think about the things that are top of mind for you and remind you that there is no question we haven't heard, and that it's okay to not know something. It's okay to need help. In fact, that's why we're here. We're here to help. We're here to answer questions. And I know you have many. In fact, frequently I've met patients who say, I don't even know where to begin. And that's so common, so common. And so my role in the treatment team is to help you figure out the things that you want to know. Where do you need support? And so you may have already encountered someone assessing different areas. Tell me about this. Tell me about that. In fact, it may even feel like we're being really nosy and prodding. And to an extent, it is that, but it's really meant to help you and guide you. And that's what we're here to do this evening.
Thanks, Eucharia. I had a question that came to me before the start, so I'm going to pose it there for fibromyalgia in particular, which is since it's such a rare cancer, and when it's diagnosed, people don't even know how to pronounce it, right? And so the question here is, how does someone know that they're two things, one's to Jim and one's to Eucharia, that their institution that actually has diagnosed them will bring them to the right people to actually treat them, whether it's that place or to refer them. And number two, to Eucharia, just how do you connect with other people, that have a rare cancer, whether it's fibromyalgia or not?
So I guess I'll take that first one. Before I do, I want to say if there's any questions among the audience about the value of the social worker on the team, I didn't include the list because I knew Eucharia would mention it. I have to say in my clinic, I'm sitting next to one all day long, and I was today, and we see the same patients together. And every family that we see sees a social worker. So it is not a judgment on anyone's resources or independence, or it's a part of a wellness team that is important. And it's about so many things beyond what people preconceive. So I'm a huge fan, Eucharia. So thank you for doing what you do.
Thank you.
As far as how do you know if someone's going to refer you to the right people, I think is your question, John. I think that brings up the question, is there a specialist in your center or in your city to begin with? And there aren't that many out there. There aren't any people who specialize in a cancer that's very rare. And there's reasons for that. It's almost impossible to do that and to be a practicing physician or a practicing surgeon, because you have to have there aren't that many patients out there with this. But you can certainly see someone who has an interest in this and sees more than one patient, and a surgeon who knows how to handle liver cancer an oncologist who knows how to handle liver cancer and isn't doing leukemia 90% of the time and then sees an occasional solid tumor. And I think that's up to the patient and their family to ask about, are there people who see this more commonly in your program that you're at? And I would hope that they would have aligned you with the group, at least at the center that you're at, that is closest to an experience level needed to care for the situation at hand. And if not, ask them why, or if they're more in the city, or have they spoken with anyone else about this? Have they sent the invitation? If it doesn't mean they can't provide great care if they haven't seen this before, but how is your care team going to link into the expertise that does exist? And there are ways to do that without having to travel. And that's a common thing that comes up is, do I need to travel for this? I heard about so-and-so here. I heard about so-and-so there. And, sometimes people do want to travel for that, and that's their prerogative. Most specialists, myself and others in the field, are happy to speak with families and speak with oncologists or surgeons in collaboration, or to help think through a challenging situation. But John, I would say ask, and don't be afraid to ask. Have you seen this before? If not, are you the person who takes care of the liver tumors here? And what do you suggest as a plan, and why? And be inquisitive. It's your life.
Thanks, Jim.
There was one other question about how to, what are the rules after surgery? Can you resume normal activities? And it's a loaded question. It depends on whether you're fortunate enough to have your tumor diagnosed before it has spread. And you can always resume normal activities and resume, usually in the younger kids within 10 to 14 days. As we get a little older, we heal a little slower, and that's all normal. But it depends on what the other part of the package of your journey is going to be. And if you're lucky enough to have been diagnosed where it was resectable up front and it comes out clean, then maybe you're just going to be watched and have scans every few months and follow up with usually an oncologist for that. If it doesn't come out perfectly clean, maybe they'll prescribe a little bit of radiation therapy to get the edges, with or without chemotherapy. The national study does ask some questions to the Children's Oncology Group about the use of chemotherapy, even when it comes out clean, for 12 weeks or so, 8 to 12 weeks of therapy. Now, if it is more than just involving the liver, surgery isn't always going to be the answer. Just because we can detect one or two spots, if we detect more than that, even when we don't detect any other spots outside the liver, we worry about something that's called cancer dust. And that's the stuff that flakes off that you just can't see on the images. People wonder, well, why, if it was completely resected, would it ever come back? It's because our imaging is only so good, and it may not pick up this dusting effect. And that's why we're testing the question of chemotherapy, even if we can't see anything afterwards. But if you have metastases to the lymph nodes or lung, sometimes chemotherapy is used. There is a misbelief that fibrolamellar does not respond to chemotherapy. That is not true. We have established response rates with various regimens of traditional chemotherapy, and people are looking at immunotherapy and other biological therapies. Not everyone responds, but the journey after surgery may involve some of these other components, or it may just be imaging. But the actual healing from the surgery itself is individualized, and often the younger kids kind of perk up earlier, but most people heal.
So I've got a couple of questions that are related. What do you say to a young adult or teenage patient facing a diagnosis like fibrolamellar? How do you help them prepare for their journey? And related to that is that teenage patients don't necessarily see eye to eye with their parents. How do you get them on the same page? Again, loaded question, which that's okay because they all are. They're all stacked on top of each other. And I would say this. One of the most important things to remember is that we frequently go to what do you say, and we skip over the fact that we need to do a lot of listening as well. And it's a balance. I don't think that there should be ever a lot of talking without listening. And sometimes that means awkward silence because someone may not know what to say, or there may not be a lot to listen to. And as a parent, it's okay to not know what to say to a young adult or teenager who's facing a diagnosis like this. But one of the things that, as parents, we want to have answers. We think that our children expect us to have answers, and many times they do. But this is one of those times where we need to think about acceptance and accepting the fact that you may not know what to say, maybe for the first time ever. But you know what? Maybe that's the place to start, to say that I'm not sure what to say, but I'd like to share what I'm feeling. I'd like to share what I'm thinking. And those may not be your words exactly. It could be some variation of that to whatever extent you're possible. But how you help them prepare for this journey is going to vary by family and by situation. This is one of those times where I encourage working with your treatment team to ensure that you yourself have had your questions answered and that you understand what may be a part of that journey, especially treatment-wise, as you've heard Dr. Geller talk about. There are some components that will be included, and then there's some that may be included. So what you say depends a lot on how you're interpreting that information. And it's okay to say, you know what, I've got some questions. Here's what I understand, but here's what I need to understand more. So your ability to prepare your family or your child for the journey really starts with you having an understanding about what that journey may entail. And it's okay to ask those questions. It's okay to ask those questions multiple times, actually, because this is a lot of new stuff. There's a lot of new words, new terms, new phrases, new specialists. There's a lot all at once. And no, teenagers, young adults even, sometimes adults don't necessarily see eye to eye with their parents. And the question is how you get them on the same page. And again, I'm going to say that you may not be on the same page. And one of the things I want to do this evening is be very honest with you. It would be great if everybody was on the same page, but you're all experiencing this as a family, but you're experiencing it differently depending on who you are in this process. So as the patient versus the mom or the dad or the caregiver, you're all experiencing it together, but from different vantage points. And so it is perfectly okay to not be on the same page. But maybe you could use that opportunity to open up discussion about what you are on the same page about. If you're not on the same page, what's happening there? Is it that there's a difference of opinion about one thing or many things? Is it that people have expectations of other people in that family system? What is it about not being on the same page? What are you hoping to be on the same page about? The idea here is that having an experience like this will challenge you. And while we hear the word challenge and think that that may not be a good thing, it could be something that opens up dialogue in your family in a way that maybe you haven't ever had to have dialogue before. And that can be extremely uncomfortable. That can be very uncomfortable. But you don't have to do this alone. That's the main thing. You can, sometimes I've had people say to me all kinds of things. And I'll say, did you talk to the doctor about that? And they'll say, well, no. And I always encourage having those discussions. Sometimes people see even the physician as the person who gives them medical information, but they want to know what's going on with you and your family as well, because that's a part of that whole discussion about treatment and wellness and health, all of those. Anytime we go to a physician, there's room to have discussion outside of what we think you should be talking to a physician about. Just like there's room for discussion with a social worker. Sometimes people would ask me medical questions and I would say, well, now that part is a question for your physician, but here's what I can tell you. So use those opportunities to keep a list of questions. If there's a difference of opinion, that's okay. Let's talk about what that difference is. Is there something that needs to be clarified maybe? Is there something that you need more information about? Or is it just that you really are in different places with this and that's new for you? So I'm hoping that that's answering the question that's coming forward. If not, please add more information into the chat and I'm happy to be more specific.
Eucharia, just a follow on to that. There's another one about quote unquote a helicopter parent. Some of the younger patients in some of our previous discussions had wanted this question posed. One patient in particular said, well, you know, when the doctor comes in, he's only talking to my parents. And I'm right there in the bed. And it's as if I'm not there. So how does that get addressed? And then the second part of that is there are other siblings in the household, but all the focus is on me. And I just want to be normal when I'm home.
Right. So yes, that does happen. There are times where I've been in rooms with younger patients as well as in rooms with elderly patients where I'll say a healthcare provider, because it's not just the physician that does this, but where someone will enter the room, sometimes maybe even a social worker, and they'll begin to address who they think is the person in the room that should be addressed. And that's an issue. It absolutely is. I've even had patients say, hello, talk to me. You know, you don't necessarily have to be as direct about it, but it is an issue, you know, because we think about the fact that this is tough enough and you want to feel like you're in the room. You want to feel like you are present, and to have someone enter a room and not address you can make you feel very much less than present. It can make you feel very much less than like this is focused on me, that this is important for me. And that's not a good feeling to have. It's just not. And this is one of those times where you're going to be learning some things like advocating for yourself and for your needs. And this may take you out of your comfort zone, but it is okay to interrupt and say, could you please address me? You know, it's not a space that people are used to being in, but it's absolutely okay to do that. But does it happen? Yes. Now, in the case where there's parents in a room, there's going to be a lot of questions, you know, because ultimately this is about love and care and wanting to know what's going on. There's so many questions, but maybe you could even have a discussion together before you enter that room. You know, who's going to ask those questions? Maybe you both have those questions, but ultimately as parents, we do, because this is the role that we've been in. This is the role that we've always been in where children are concerned. And whether you're a teenager or a young adult, for parents, sometimes it's one and the same, because this is my baby, right? Whether or not you agree with that. But that's ultimately that feeling. And so that feeling of that need to be what you may experience as a helicopter parent, that need is there still, because it's ultimately about wanting to just be present and protect and all of those things that are inherently, you know, good things. But it may warrant a discussion. It may warrant a discussion. The discussion doesn't have to take place necessarily in that exam room in that moment, but it may warrant a discussion before that next appointment, though, so that we don't repeat the things that didn't make you feel so good in that last appointment. Dr. Geller, before I move on to the next question, it looked like you wanted to chime in on this a little bit, and I didn't want to skip past that.
Oh, thank you. What you were saying resonated with me. As a pediatric oncologist who does a lot of adolescent, young adult, this dynamic is an everyday dynamic. And what I find helpful is understanding what the goals are of the patient first and the goals of the family, and to find a way to give voice to both, voice to the patient and voice to the family. And I think those goals and those voices are what you talked about of getting in sync, not in sync. And there are times where, as a care provider, and if you're a family member in this audience versus a patient, where a physician may cut you off and try to zero in on the patient, whether that patient's 12 or 13 or 22 or 23 or older, and say, well, what are you thinking? And I do this often where I put my hand up and say, hold a minute, parents, and that might be an uncomfortable feeling for you if you're that parent. And I think having a care team that's going to help give you your voice and feel respected and heard and understand your goals, but the priority has to be the patient's voice and goals. And there's a way to do both, and you shouldn't feel slighted if your care team is focusing sometimes on the other voice in the room and not just yours. And I think it's important to give space for that to happen. And I think you've touched on that, Eucharia. That's all I wanted to add was that voice and those goals. They can be really helpful in structuring those dynamics.
100%. I'm so glad that you added that. Thank you. And Sandy, I think the other part of your question, which I'm paraphrasing, but just had to do with a teenager or young adult even feeling like, but there's other kids in this family and now everybody's focusing on me. And that's real. That is absolutely real. And you know what? It's okay. It's a feeling that, you know, it's almost like that selfless feeling, like there's other people. Why am I getting all of this attention? And the reality is you're getting all of that attention because you need all of that attention right now. And, you know, it could be that at some other point, there will be another child in that family who also needs, you know, family or friends to rally around them. And that's what family does. That's absolutely what family does. And it's about concern. And, you know, again, I go back to the communication piece because communication is everything. Communication is not just something that we should be talking about with, you know, providers. Communication is something we should be talking about within our families too. Because yes, there's a lot of focus right now, but there's a lot of focus that's needed right now. There's so much information. There's so many decisions that need to be made. This is all new. It needs to be processed. There are things that people need to learn about this, you know, so there's a reason for that hyper focus, but I also know that it's a very real thing to say, but I don't necessarily even want this much attention. I feel like my sibling is, you know, giving me the look like, oh, here they go getting this attention again. But, you know, there are certainly ways to still maintain some of the other aspects of your family unit that does, you know, tap into what's going on for other children. You know, maybe there are times where during the day you're focusing on what you need to at the doctors and that sort of thing, but maybe you can find a way to think about, you know, one of the things that we used to do before all of this is that we used to have a family game night, or maybe we used to enjoy sitting outside, or we used to enjoy dinner together. Even if there's that one thing that your family continues to do that made you feel together as a family, then you can continue to do those things even alongside giving that needed attention to the child who needs it the most right now. And, you know, you can even have a discussion about that in your family. And certainly this is going to vary depending on the ages of those other children in the family, but it's okay to have a conversation to talk about why there's this increased focus. And ultimately, that usually brings up another question, which is, how much do you say to the other children? How much do you explain to the rest of the family? And that also is going to vary by age. But the one thing I will say is that as parents, there is this need to realize that whether or not you say something to the rest of the family, they will ultimately know that something is going on. Something has changed, something is different. And so I would encourage you to not go with, let's say, nothing, because whether your child can express to you, those other children, whether they can express to you that they've noticed something different. We notice that mommy and daddy are gone most of the time now, and my grandmother sits at the house with me to help me with homework. That's a change. And they notice those changes. They notice changes in behavior, changes in language. When you're feeling tense or apprehensive, they notice all of those things. And so, you know, it's really getting with someone on that treatment team to talk about your family dynamics and to understand how to help the other members of your family figure out what's different, whether you think it's a child that's at an age that has language or not for what's going on. They absolutely are still part of what's going on. Once again, Dr. Geller, I saw you come off mute. So Come on and
Yeah.
join me in the conversation.
Yeah, it would help to know the age of our
Yes.
attendees, patients. What I tell all of my other parents of the kids I treat, whether those kids are 8 years old or 28 years old, and I see both, is that whatever you're trying to protect them from, you can't.
Right.
You can't, because what they're going to imagine is going to be, dare I say, worse than the reality. The imagination can go lots of places, and the more you do backroom discussions with the physician, and for the longer periods of time, they're, even though they're on their iPads for the kids or otherwise, they're wondering what's going on. And no, but their kids aren't that stupid. And
Absolutely.
I really strongly endorse open dialogue, particularly with the patient. There's a couple questions that came my way. Should we switch over or?
Go right ahead.
Okay. So one of the questions was about concerns for relapse and how often do people need to come back? I heard at a prior event, one of the surgeons saying that it always comes back. It can be late. It could be 10 years from now. It could be 15 years from now. That's not true. It doesn't always come back. And I think that's an important thing. Sometimes people give you impassioned opinions that aren't always evidence-based. As far as what we know, there are survivors of this cancer. And I've seen it. I have patients that are more than 10 years out that are alive. If it's all resected and it's all out and you finished your therapy, what I recommend is scans every 3 months the first year, every 4 months the second year, every 6 months the third and fourth year, and then, less over time. And the intensity of the scans, whether they're cross-sectional or X-ray ultrasound versus CT or MRI, also decreases over time. The areas in risk for relapse are significant. If it was metastatic to begin with, the risks are much higher. If the lymph nodes were involved to begin with, but could be completely resected, you need to keep a very close eye on that lymph node chain going up the body, particularly from the belly right up into the mediastinum, which is a very common pattern for fibrolamellar carcinoma. And you need to make sure you're imaging the whole area. And they can come back. And I've had that happen, and we've reoperated and watched. And I've got a patient who's 2 years out from a second surgery doing fine. So you do need to have surveillance afterwards. The risks of relapse are much higher if you had spread to begin with. But I wouldn't want to say it's hopeless, and I don't believe that's true. And we continue to try and find better therapies with the help of the Fibrolamellar Foundation. And if you have a relapse 5 years from now, who knows what drug we will have found by that time. So I think it's important to undergo your surveillance if you can get into a remission state, which is no detectable cancer, to be followed. And there's also reason to hope. I'll pause there, Sandy, and see if anybody want to ask questions. I'd love to, even if in the chat room, if the attendees would signal to topics that Eucharia and I haven't covered that are of interest to the group before the hour runs out. This is a great question. This is a great question.
You saw it, right?
Oncofertility, the ability to have children. How do I speak to each patient? So we're a little more proactive. We have been for the last 10 years in addressing this right in the first few days. In fact, everyone that's diagnosed at our center, automatically our EPIC EMR, electric medical record, signals to the oncofertility team the name and diagnosis, the patient's medical record number, and that oncofertility representative contacts the oncology attending right away and dives into the details within the first week. It's important to dive into those early because some of the therapies could impact fertility. The therapies that could impact fertility generally aren't used that commonly for fibrolamellar carcinoma. Unless the radiation's affecting gonads or uterus, which is pretty far south compared to where the cancer typically is when radiation is rarely used, that's not going to be an impact. The cisplatin or doxorubicin or gemcitabine or oxaliplatin or the lenvatinib or sorafenib and the PD-1 inhibitor drugs aren't thought to cause infertility at very high rates. So most people diagnosed with fibrolamellar carcinoma would be categorized, whether getting chemo or not, as low risk for infertility. There's a low, intermediate, and high risk. And in a low risk setting, most oncofertility experts will counsel that ovarian cryopreservation or testicular biopsy or other mechanisms such as sperm banking and things aren't necessarily necessary or of high index. Now, some things are simple. Sperm banking is simple for men, and that is something that we often consider right from the get-go. Even though the risks for infertility are low, the intervention is low risk. But to start taking somebody's ovary out or biopsying the testicle, the risks aren't high enough for infertility to cross over into those indications. We discussed this right away. This is a high priority item. It should be discussed. I don't know if the adolescent, young adult, the children's hospitals per se are more in tune with this than some of the adult programs, but I don't know if that's true or not. The oncofertility aspects of cancer care are embedded into the National Cancer Network, the NCCN guidelines now, so it should be part of standard of care to be addressing these things. And it needs to be discussed openly. These are adolescent young adults. It's awkward, but they're wondering about it too. And it's something that is important.
Eucharia, did you want to chime in on that one in terms of how to have these discussions with families?
Actually, I think Dr. Geller covered that one very well, very specific. One of the things I will add, just in general here, is that I hope what's coming across very clearly is that all questions are okay to ask. Sometimes there's a level of discomfort with asking certain kinds of questions, but they are important. And whether or not a physician or anyone on that medical team can respond to the question or to really address your needs, they have to really understand what the concerns are. And so, sometimes there are questions that people didn't feel comfortable asking their physician, again, because they thought, well, that's not something I ask my doctor. So they've asked me. And what I do is I refer them right back, and try to help them think about how they can ask that question. So I'm just going to underscore that all questions are okay to ask. Any question is okay to ask. The other thing that I would highlight is that the treatment team includes you. You are a part of that treatment team. So many times people think about the treatment team as the experts that are around them. And 100%, we are experts in some aspect of your care. But the bottom line is you are the expert in what it means to be who you are in the life that you were already living prior to this diagnosis. And your ability to participate in, talking about things, asking about things, making decisions, you are an integral part of that team. And I bring this up because I think it changes the dynamic when people just say, oh, well, they know best. And yes, there are things that we know best about, but we also want to understand what you know best so that we can really help you to, just be fully present with what's going on. But the flip side of that is getting to know your treatment team members. Who's on your team and what do they do? Whether you think you will need them or not, hopefully you're in a situation where the team is present and introducing themselves to you and talking about how they help, or showing up for you in situations where you do need help so that you don't even have to ask. But if there's someone on your team that you don't know or you don't know what they do, ask that question too. So it's really about this information exchange back and forth. And we want you to be a part of that as much as we want to be there to serve you too. So Dr. Geller, I don't know if you want to add anything to that.
No, it did. The topic of oncofertility made me think of the second big topic where I'm often asked about which is why did this happen? And it's definitely
Yes.
a turn to a different discussion. But Eucharia,
Yes.
you're finished. If you're
Please.
finished, okay.
I agree. Very big discussion. Yes.
Yeah, and for the family members, me, John, in the Fibrolamellar Foundation have heard things that I haven't heard yet because they're collecting lots of information and insight. I have yet to see 2 family members with this cancer. I'm not saying that it hasn't happened, and maybe the Fibro Foundation can advise us as to whether they've heard of a case like that. But I've never seen more than one family member with this form of cancer in the family. In general, these what's called fusion positive cancers, where 2 genes that aren't supposed to be next to each other miscross in the cell, and then a cancer becomes, generally aren't thought to be hereditary. This is a non-hereditary cancer. It's not something that parents passed off to their children. It's not something that a patient's going to pass off to their child. So this is a fluke event. It's not genetic, not thought to be genetic in a hereditary sense. And that's important to know. The other thing is we're not aware of any associations with did I smoke in utero, while my baby was in utero and I was smoking, or I had a glass of wine, or one parent works in a metal shop and is exposed to environmental toxins. We haven't been able to link this cancer to any of those things either. And I think it's important for families to know that unfortunately or fortunately, no one's to blame. And the patient isn't to blame. It's not anything they did. But you're not to blame either as a family member. This just happened. It's not a satisfactory answer, but it is an answer as to what we know now. And, it's sort of a rule out process right now. We really don't think it's hereditary. We haven't identified any typical environmental exposures that would explain this, or diets that would explain this. There's one exception where I've recently seen a fibrolamellar cancer evolve in somebody who had a congenital heart surgery, something called a Fontan procedure. And we know that carcinomas of the liver happen at a higher rate in patients who have congenital heart surgeries with a Fontan operation. We just didn't know fibrolamellar was one of the subtypes that could happen. And we recently did see that subtype in that situation where the blood flow to the liver and the pressure of the blood within the liver is altered because of physiology in that patient's body. And we may learn that altered blood flow and pressures within the liver and the way that the biology in the liver is functioning could be part of the trigger to this form of cancer, where a cell acquires this messed up gene, and then it's not in every patient's gene, it's just in the cancer, and it evolves. So it's not that we know what causes it, but we're pretty sure we know what doesn't cause it. And I think that can be important. And that's a topic that we haven't discussed up to this point.
Sandy, do we have any other questions in there? I know Eucharia has some slides that she might be able to show too on the resources for CSC, but go ahead.
I know before she does, I think we might have one coming up, but there was a question earlier about nutrition. So patient is undergoing treatment, goes home. Are there any lifestyle changes or anything that a patient might be, or family might have to alter or change or focus on?
This is
some of the questions were vitamins, nutrition, extra this, eliminate that. What do we do? Yeah.
So this is a really important question. And I'm going to answer it in a couple ways. First, it gives me the opportunity to tell people that there is a unique biochemical phenomena that occurs with fibrolamellar carcinoma. We don't fully understand why it happens, but something about the cancer makes the liver function differently, and it makes the production of ammonia go up. And I've seen this in a handful of adolescents now, not just, and we do recommend that people check ammonia levels. If you're keeping notes out there, ask your doc to check an ammonia, because we do know that for some reason, some patients, particularly when they're on chemo, but even if not, can develop something called ornithine transcobalaminase deficiency, which is you're not going to be tested on that. It's OTC deficiency for short. And what happens is their ammonia levels go up. They can get confused, not think straight. It can be very subtle, or it can be full-blown encephalopathy where they're obtunded and they're in the ICU with altered mental status. And I've seen it in a decent percent of patients who have fibrolamellar. It's related to dietary because it's a protein metabolism thing, but it's not that the patient is genetically not processing proteins right and that you should avoid proteins. That's not what I'm trying to say. This is just take a note, ask your doc to check ammonias. We've reported on this and built it into our national protocols now to encourage it, but most doctors don't know that. As far as the dietary phenomena, I'm not a big fan of diet manipulation. I think your doctor needs to know about everything that you're doing. Certain vitamins will impact certain chemotherapies' ability to work. So depending on what chemo you're on, your doctor does need to know what vitamins you're on, especially the higher dose vitamins. Alternative therapies is the same. Some of these interact with chemotherapy, interact with kidney function. There are certain ones, I'm not going to get into this deep discussion about it, that can be harmful. But if you give a list of what you would like to take and give it to your physician, usually they'll share it with their pharmacist and they'll go over that. And as long as it's not harmful, most doctors at this point in time in the 21st century will say, fine, go ahead. It's not going to hurt you. Don't know if it's going to help, but not going to hurt you. I'm not a huge believer in low sugar diets or low fat diets or otherwise to manage this. The important thing is to make sure you're getting enough calories and you're not losing weight. And those calories, I tell my patients, can come as, you might not agree with me, but they can come as ice cream shakes for all I care, as long as you're not losing weight. And, to try and do low sugar diets, it's almost impossible in younger kids. You'd have to do what's called a ketogenic diet. And there the sugar levels go from 80s to 40s or 50s. And it's basically eating bacon fat every day. And that's not what you want to do. It's not what you want to put your child through. Your body will maintain a sugar level inside itself, particularly when you're young and have no pre-diabetic issues. Your blood glucose level is going to stay, 80, 90, or 70, no matter what you eat. Now, if you indulge and have a large hurricane at Dairy Queen, and then you have 4 Milky Ways, you might get your sugar level into the low 120s or low 130s for a transient period of time, or maybe even a little higher. But when you're young, the body has so many intrinsic mechanisms, insulin, glucagon, all sorts of other hormones, to keep that sugar level in your body fairly stable the entire time. And the tumor cells are going to see the sugar level in the blood. So it's very difficult to lower the tumor's exposure to sugar. If you read about how sugar does feed cancer, yeah, it feeds every cell in our body. And it's just very difficult to really alter that in the younger patients. And I think you have to consider that when you think about quality of life and the other aspects of the journey. Well, before getting too caught up in diet, I focus on calories.
Right, thank you. We do have one more question, and maybe this will be our final question. And then Eucharia, I don't know if you're going to talk to us a little bit about cancer support community and some other things. The question is, and I think you both may have touched on this earlier in the hour, in not as directly in answer to a direct question like this, but it says, how do you deal with patients that have read the statistics on FLC? What do you say to encourage the patient and the family? So I think this is for both.
Yeah, well, maybe I can start because of the prognostic data. So what statistics have you read is my question. The data that we have in pediatric and adolescent FLC is that the outcome is not very different than other, hepatocellular carcinoma. Response to chemotherapy is not that different. And the event-free and overall survival, which is just time marks, isn't that different. And so you're talking really about the setting of where it has spread, because where it hasn't spread, there's ample reason to be hopeful if you can get it all out and monitor. If it has spread, there are anecdotal reports of complete responses, there are reports of patients who've survived this. And the other thing about the data is that it's limited and it's weak and it's mostly retrospective and filled with selection bias, and we don't know all the stories. So from a scientific perspective, this cancer is still being described. And that's where places like the Fibrolamellar Foundation really are high value, because we're centralizing knowledge in a cancer that's rare. And really, the data is limited. There isn't a lot out there. And I think every individual is an individual. So I would be cautious about getting too pessimistic. On the flip side, I'm not trying to give you false hope. If you have some family member who's got widely metastatic disease, it is a disappointing data set out there of when it's spread, the outcomes are often not great. But I've treated patients who didn't survive for 5 to 7 years. Sometimes it can be a slow process. And again, new drugs evolve. And sometimes you are lucky and it does all go away. So you have to individualize that answer, but those are some broad points. I do want to answer the other question in the chat room, but I'll pause to see if Eucharia wants to add to that.
I will just say quickly that I echo your comments, Dr. Geller, because, it's not that we're saying don't read and, become more informed. Certainly, we want you to do that. However, just with everything else that we've talked about, this is an opportunity for that communication back to your treatment team, because it is important where you're getting your information, because it's easy to read something and assume that it applies to you, and it may in parts, and maybe in other parts it doesn't. So this is where you really want to bring that information, bring the statistics that you found, bring any information that you have found to that treatment team to say, hey, I was reading and this is what it says. It provides an opportunity for that individualized response, and that's usually best. So I echo what you said, Dr. Geller.
Thank you for your added comments. Somebody in the audience asked about a urea cycle disorder causing elevated pneumonia. I was actually referring to that. Ornithine transcobalaminase deficiency, or OTC deficiency, is an enzyme in the urea cycle. It's not a genetic phenomenon with fibromyalgia carcinoma. For some reason, there's a phenotype or an expression, or if you look at all the amino acids in the blood, it looks like somebody who has hereditary ornithine transcobalaminase deficiency, where the arginine levels go way down, and there's a way to diagnose it. Again, we don't know what the biochemical trigger is to create that secondary phenomena, and we're studying it quite avidly. Some of the research that the Fibrolamellar Foundation is supporting, I believe, is going to some labs that are trying to uncover the source of that. Because if we can understand why this cancer in particular triggers this chemistry, we'll know something more about this cancer, and ideally we can take advantage of that and treat it better. But that is what causes the elevated ammonia, is this acquired OTC deficiency, which is in the urea cycle. And yes, we see it. I see it frequently in fibrolamellar patients. I would venture to guess it's probably a quarter of the patients that I've seen have had it, maybe 1 in 5. Whether it's more prevalent or more common than that at a low clinical level is not known, because people don't routinely check ammonia levels. It's only when someone comes in obtunded and into the ICU where they realize this. And it's treatable. You give a patient Ravicti and arginine, and the ammonia normalizes, and they can go on a regular diet and eat protein, and they don't wind up getting readmitted with obtundation from the elevated ammonia. That is different from end-stage liver disease in patients whose liver is too far advanced and filled with cancer and doesn't have enough normal liver to function. That's a different cause for elevated ammonia that is separate from what I'm discussing now. But it is this urea cycle disorder that's acquired is a unique phenomenon to fibrolamellar, but it is very treatable, which is why I encourage ammonia monitoring, because you can take that issue off the table for a patient with some management.
Thank you, Dr. Geller. Any more questions from the audience? Okay. Eucharia, do you, so I guess we're gonna wrap up in a few minutes. So Eucharia, I'm passing it on to you for some closing remarks on cancer support community and what you offer, and then of course to Dr. Geller, and then we will thank the audience. And just let everybody know that we're going to post this as an archive on the foundation's website. So Eucharia?
Okay, sure thing. Let me share my screen. Okay, are you seeing a slide presentation? Yes,
Yes, we
okay,
are.
excellent. All right. So I'm going to run through these. Some of them I may skip through because we've already covered some information just that I included in general. That's me. So our mission at the Cancer Support Community is to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community. And I won't cover everything on this slide, but you'll see that we have 3 pillars, which are patient services, insight, and advocacy. And of course, the patient in the center. And for our direct services, we have had more than 500,000 visits by patients and loved ones to our 175 locations each year. And that's 3.2 million unique visitors to our website annually. I'm going to cover my Lifeline and the Cancer Support Helpline in a few slides. So I'm going to move on to our Research and Training Institute, where we're doing psychosocial research. We've had nearly 15,000 participants in our Cancer Experience Registry, and I'm going to share just a few data points from our Cancer Experience Registry so that you can get a flavor for the kinds of questions that we ask. We have more than 1 million data points on these patients. You know, we are interested to know what is the experience with having a cancer diagnosis and how does that impact various parts of one's life. And then we have our policy and advocacy through our CPI, which is our Cancer Policy Institute, which is focused on 3 pillars, which is quality, access, and research. And in addition to that, we have a grassroots network where we have lots of patients and supporters who can also be involved in that policy and advocacy. Here we're talking about our national reach, and I've talked about our 175 locations nationwide, and we have locations in over 50 markets. And these centers prior to the pandemic were in-person service centers. However, we, like many other organizations, pivoted to offer virtual programming, and at this point, we're doing some hybrid programming as well. This is just a representation of what this must feel like, whether you are the patient or the caregiver, just a lot going on, not sure what's happening. You might be a person who doesn't even like roller coasters and yet you're on one. So this is a visual representation of what this time is like, feeling overwhelmed with so many questions, maybe not even questions that you formulated yet, but just acknowledging what this time is like. We've talked about some of these, but I'll highlight them again. Some of the universal challenges of cancer are things like feeling a loss of control, sometimes feeling unwanted aloneness, which may not mean that you are actually alone. Sometimes it does, but maybe feeling aloneness because there's not someone else that you know or have spoken to that's experiencing what you're experiencing, particularly at this age. And you may be feeling a loss of hope, which Dr. Geller already addressed for us. From that Cancer Experience Registry, these are some of the kinds of data points that we capture. So what we know is that 41% of our participants were moderately to very seriously concerned about disruptions in work, school, or home life. 1 out of 2 did not feel prepared to discuss treatment options with their doctor. 53% of our participants expressed worry about the future and what lies ahead. And 44% reported health insurance or money worries. I selected these out of many statistics that I could have selected because maybe something that I've included here is resonating with you to let you know that what you're experiencing may feel overwhelming, but you're certainly not alone in feeling that. And so knowing that can help you to begin to explore what some of the ways are that you can get the support that you need in each of these areas. We got a question about talking with children, teenagers, or even young adults. And what we know is that 66% rather of parents answering a cancer support community survey said that their child or children did not talk openly with them or share their feelings about cancer. We've already covered the things that you see on this slide here in some part or another, but where you begin really varies. These are some of the top 10 things that people bring up or are concerned about. And so you may be a person who immediately is beginning with needing that emotional support. Or perhaps you're a person who's already asking about how do I become informed? Or should I get a second opinion? And where do I do that? Are there clinical trials? How do I participate in that? Where do I find out more information? No matter where you begin, it could be the beginning. So there isn't a particular place where you need to begin, but you want to make sure that you do have the facts. That's one of the most important things up front. And from there will be questions and concerns. And your questions and concerns as a patient may not be the same questions and concerns that your parents have. And another very important thing is to write it down. There's so much information, and write it down doesn't necessarily have to mean write it down. I've had patients come to appointments where they're, taking notes on their phone or on their laptop, whatever's comfortable for you. We talked about some of these things to remember already, getting to know your team members, asking questions. Cancer affects family in many ways. So I'm going to move on to the next slide. The cancer support community has many, many different products for you to think about as you are having questions. For example, educationally speaking, we have an award-winning series called Frankly Speaking About Cancer. These are just 3 topics that I selected: making treatment decisions, caregivers, and coping with the cost of care. But you may find that there are other topics that speak to your situation at this time. And I have our web address here. But even outside of Frankly Speaking About Cancer, our website has many places for you to read through our blogs. We've got a radio show there. There's other places where you can learn about what does it mean to be newly diagnosed? Where should I be focused? And so I would encourage you to visit. Our cancer support helpline, you see the phone number here. We actually are open Monday through Friday, 9 a.m. to 9 p.m. Eastern. And Saturday and Sunday, 9 a.m. to 5 p.m. Eastern. And we offer free navigation for cancer patients or caregivers by phone or live web chat. And we can do that in a variety of languages. And these are some of the things that we can help with, connecting to national resources, treatment decision planning, and giving that guidance and support that's needed. Recently, I was taking calls on our helpline, and someone said, I'm not even sure why I called. I just know that I came across your information and figured I would call. And we're there for that too. As we think about some of the other areas where we're specialized, we can provide information about clinical trials or finances. There are many questions about finances and insurance. Pediatric oncology, we do have a specialist that can answer some questions and help to get you connected to the resources that you need, as well as genetics and genomics. My Lifeline is our digital community, and you'll see some of the statistics that I included here. We have 30,000 active members, and our discussion boards are, very active with over 5,000 participants. The discussion boards are where people can connect if you don't want to call someone or you don't want to read through one of our, let's say, educational pieces, but you just want to connect with someone. There are groups for caregivers. There are diagnosis-specific groups. You may be someone in your 20s who wants to connect with other patients in their 20s who are living with cancer, maybe even outside of the diagnosis, but just the experience of having cancer as a younger person. Or if there's a topic that you don't see, you can introduce a new topic to connect with others. But My Lifeline is sort of like taking Caring Bridge and Facebook, and this would be that product. If there are things that you need help with, like getting to your appointments, or I need someone just to help with things around the house because I do have other children that I need to support, or I have siblings that I need support with or for, you can set up a helping calendar where people can, you put it out there, this is what I need, and it gives people an opportunity to sign up to say, I can help with that on that date. If there is just this feeling that, my goodness, I just keep having the same conversation over and over with everyone, you can create your own personal page where you provide updates, and maybe you update it, or maybe you appoint someone to update your page so that you really begin to manage how and when you give information. If you want to find an actual location, you can do that as well. In fact, on our website, we have a tool where you can find a location near you. Now, we primarily serve patients who are 18 and older. However, you can, still connect as that caregiver, and you just enter your address and it'll tell you if there's a location near you. If there's not a location near you, or if you're having trouble navigating that, then you can call our cancer support helpline, and they are happy to get you connected with whatever resources or information, including to one of our affiliate locations or healthcare partner locations. And that's really what I wanted to share, just a really brief, quick, high-level overview of who we are and our services. And I appreciate the opportunity to do that and to be here with you today.
Great. Eucharia, thank you so much. Dr. Geller, I know I had to sign off, but we're really thankful for his comments and insights. This is an important area, and certainly I'm glad we captured this, certainly your comments on video. Certainly for anybody who's still on, if there's any questions, you can send them to us at info@fibralfoundation.org, and we'll be happy to get back to you. But again, thank you so much, Eucharia, for your time and your insights. Sandy, thank you for putting this together. And we appreciate these great seminars. Take care, everybody. Have a good night.
Thank you, everyone.